السلام عليكم ورحمة الله. هنتكلم إن شاء الله النهاردة عن Imaging of GIT disorders. The curriculum of the lectures, we will speak about the esophagus, stomach, biliary system, and the colon. We have different imaging modality for the esophagus imaging. We have barium study, which is the standard imaging for the esophagus. Then we have a CT and MRI for further delineation of the lesions of the esophagus. If we, for example, discovered any malignant lesion within the esophagus, we can stage or search for its metastasis or search for its extension through using CT or MRI. The esophagus has anatomy as other parts of the GIT, including the mucosa, the muscle layer, and the external serosa. As we see here in this barium study, we see here the linear of the mucosal lining of the esophagus in the first exam of the barium, with a thin, dense layer of the barium forming these lines, 3 to 4 lines of the normal mucosa of the esophagus. This is the normal appearance. As regards the esophagus, we have a normal peristalsis, including primary contraction and secondary contraction. The primary contraction is the first bolus moving through the esophagus through contraction above and relaxation below, and then the area below become contracted and the below become relaxed, and so on. The secondary contraction follows this primary one to make sure that the esophagus is empty or has been moving all the food inside. But if we have an abnormal movement or abnormal contraction, like tertiary contraction, which is useless but painful contractions within different parts of the esophagus, it may occur in old ages, in neurologic disorder, just like dermatomyositis, scleroderma, polymyositis, esophagitis, and in other neurologic disorder. And also the achalasia, which we will discuss later, is one of them. We will start with the pathology of the achalasia. The patient presented with progressive dysphagia, which the whole mark of the disease is stenosis, just like here in the lower part of the esophagus and the cardia or gastroesophageal junction. Then we have a dilatation above this area, forming funneling of distal part of the esophagus. This will lead to accumulation of food, as we see here, food and the gas within the parts of the esophagus. It will be mixed with the barium, as we see here, and this is the end part of the stenosis. This is what appeared in the esophagogram. It occurred due to esophageal ganglion cell disorder, and lead to one of the swallowing disorder of the Another pathology we'll speak about is the diverticulum. Diverticulum can occur in any parts of the GIT. As regards the esophagus, we have two types of the diverticulum. Diverticulum, by definition, is the outbouching of the part of the wall of the esophagus. It may be due to bulging diverticulum or traction diverticulum. Bulging diverticulum means the increased pressure inside the esophageal lumen leads to extrusion part of the wall throughout this contour of the esophagus. Just we see here, this is a diverticulum. But in traction diverticulum, there is a fibrosis outside the esophagus, for example, in the inflamed lymph node or fibrosis within the lung, and lead to traction of the parts of the wall of the esophagus, forming what's called traction diverticulum, which mostly in the middle part of the esophagus. We have different types of bulging diverticulum, just like Zinker's, Kelly and Jamison, epiphrenic diverticulum, mid-esophageal, and aortopulmonary recess. In this case, we see the Zinker's diverticulum. We see here posteriorly in the upper cervical region. This is the direction of which we can see this aortopulmonary window diverticulum in the mid-chest, and in the neck laterally we have the Killian-Jamison diverticulum. Another pathology with the esophagus is the hiatus hernia. It's midway between the esophagus and the stomach, in which we have a part of the stomach is sliding through its hiatus in the diaphragm to be in the chest or the posterior mediastinum. We have different types: the sliding, the paraesophageal, mixed type, and short esophageal. The sliding is just the part of the gastric mucosa is going up to cross the diaphragmatic copula. This is the sliding, simply the sliding hernia. But we have the hernia here, as we see, there is a outbouching from the mural part of the esophagus from the stomach. And also we have, this is here the arrow is referring to the gastroesophageal junction, is seen above the diaphragmatic copula. So this is a mixed type of the paraesophageal, which looks like the verticulum from the stomach or from the gastroesophageal junction is above the diaphragm, and also the gastroesophageal junction is above the diaphragm. This is the mixed type of this hernia. And we have the severe form, which is a gastric build up or gastric herniation from the hiatus. Also, we have the gastroesophageal reflux. Normally, when the patient is in Trendelenburg position, if the gastroesophageal junction is patent, there is no reflux of the content of the stomach. In our imaging is the barium, no reflux to the esophagus. But in patient who is incompetent or in sliding hernia or any type of hiatus hernia, there will be a reflux of the barium. As we see here, this is in Trendelenburg position. The barium is seen refluxing to the separate part of the esophagus, reaching here the upper part of the chest. Okay, and this is a gastroesophageal reflux. This hiatus hernia, which lead to reflux, lead to inflammation of the wall of the esophagus, especially the lower third. There will be an esophagitis, which is caused by this reflux, and cold reflux esophagitis. It will appear as a mucosal fold. Here we can see this mucosal fold is second. This is the second mucosal fold as we see here. Okay, and also we can see here this is an ulcer within the mucosa. It can be described as accumulation of the barium through a defect through the wall, and there is a irregularity in the contour. As we see here, there is a irregularity of the contour of the esophagus. This is what's called esophagitis due to the reflux. Also, we can pass to the Barrett's esophagus, which is a metaplasia, columnar metaplasia of the lower part of the esophageal lining due to reflux esophagitis, and it is precancerous. It can be appear as a web, or as we see here, or just ulcer, or as we see here, there is a reticular mucosal pattern here. Okay. We have different types of neoplasm affecting the esophagus, and as any other parts of the GIT, we have a benign neoplasm and malignant neoplasm. Benign neoplasm is appear as a protruding part through the wall of the lumen, or what's called a filling defect of the barium. It may be as a pathology. It may be papilloma, adenoma, leiomyoma, any mesenchymal tumor, just like lipoma, granular cell myeloblastoma, and others, and any types of cysts. We can see here there is a filling defect, as we see here. Okay, this is a filling defect within the wall of the esophagus, as we see here. Okay, in the lower part of the esophagus, but it has a smooth border, and the barium is passing anteriorly and beside this mass. This is appearance of the benign lesion of the esophagus, maybe cyst or benign neoplasm, and this is leiomyoma. But if we have a malignant neoplasm, we have a different appearance in the malignant neoplasm, even in any part of the GIT, as its alimentary tract. We have it may be appear as a papilloid mass, or papilloma, papillary carcinoma. It's a polypoidal-like mass, and it may be ulcerating mass, maybe appear as an ulcer or as a stricture. We can see here, and there is a filling defect in the wall. I will delineate this mass. Okay, and we have areas of destruction. Here, as we see here, there is areas of destruction within the mucosa. These areas of destruction within the mucosa is formed by this mass. If this mass is ulcerating, we will find an filling defect here. Okay, and if the mass is annular, we can see another obstruction from the other side, and leading to a malignant obstruction. Here also, we can see here a filling defect within the part of the esophagus, and we can see an areas of destruction of the mucosa. Maybe we can see it here or here. There is a destruction of this mucosa, and also the lining outside is seen some sort of retraction. Okay, it may be appear as a polypoid, verrucoid, infiltrative, ulcerative, or superficial spreading, stricture, or pseudoacasia. The pathology may be squamous, adenocarcinoma, spindle cell carcinoma, leiomyosarcoma, lymphoma, or metastasis, rarely. Then we will speak about the stomach. Has the cardia, the gastroesophageal junction, the fundus, the body, The antrum, we can see here the outlet or the pyloric sphincter after the pyloric canal, and then the duodenum. We can image the stomach mainly by the barium meal, and here is the appearance of the barium meal. We can see here the fundus of the stomach filled with air. Then this is the body of the stomach. This is the antrum or pyloric canal, and this is the pyloric sphincter here, and the first part of the duodenum forming the duodenal cap, and we will discuss it later. Then we have the second part, third part, and the fourth part of the duodenum. This is the jejunal lobes as we see here. This is the appearance or normal appearance of the duodenal cap as we see here. This is the canal, okay, and this is the duodenal cap. It's directed upward. Any deformity of this normal appearance of the cap leading to detection of any pathology. We can see here the pyloric canal, the pyloric antrum, the duodenal cap, and other parts of the duodenum. This is the appearance of the duodenum and the stomach in the upright position of the patient when doing the barium meal. Okay, when we are speaking about the stomach, mainly we can speak about the ulcer. We have two main ulcers of the stomach. The benign ulcer is a malignant ulcer. The benign, which is a peptic ulcer, the other is a malignant ulcer. We will discuss the differentiation between both. As we see here, this is the ulcer and this is another type of ulcer, and we will discuss. Firstly, we have a sign suggestive of the benign gastric ulcer. The outbouching of the ulcer crater beyond the gastric contour. Here we can see this is the ulcer, what's called ulcer crater, or اللي هي فوهة البركان. This is crater filled with the contrast and is seeing smooth outline. And also we can see this ulcer is deep, not a shallow one. And also we can see this is mound or what's called elevation of the surrounding mucosa, and we have these lines which is continuous down to or up to the crater, as also in the other image. We have a multiple ulcer folds or gastric folds directing and reaching the part of the crater or the center of the ulcer. This is the chronic ulcer. This is the appearance of the chronic benign duodenal ulcer. We have this malignant one. We can see here there is an interruption of some of the folds here. Here the ulcer is not deep, it's a shallow one. We have an irregularity in this outline of it, and also we have as a Karman meniscus sign here. This is the Karman meniscus sign. We can see here. This is the meniscus. Okay, we can draw it here. This is the meniscus of the ulcer. This is a differentiation point between the malignant and a benign. Also, we have another appearance in the malignancy of the stomach, which is a diffuse infiltration of the wall of the stomach, leading its decrease its size. We can see here this decrease in the size of the stomach from this level up to this level. This is due to the mucosal infiltration or the mural infiltration of all parts of the stomach with irregularity of this mucosa, and this is appearance related to the what's called lens plastica أو الكيس الجلد أو الكيس البلاستيك اللي هو collapsed after filling of this wall by the malignant mass. It can be not specific only for the carcinoma. It may be lymphoma, may be gastric diverticulum, which may be disappearance, inflammation, scarring, and even amyloidosis. What's called lens plastic. We have a different imaging models for the colon. We can do plain X-ray, we can do barium enema, virtual colonoscopy, MRI. If we suspecting here we can see the normal appearance of the colonic parts. Here is the cecum, the ascending colon, the hepatic flexure. This is the transverse colon lying up, and this is splenic flexure, the ascending colon, and last by the sigmoid colon. Here is after inflation of this by gas. We can see here the parts of the colon here distended by gas. This is normal. If we have an intestinal obstruction, so even it's a small intestinal or large intestinal obstruction, we will find that in this erect view we have multiple air fluid level. As we see here, it's step ladder appearance. We have multiple air fluid level as we see here. This multiple fluid levels is diagnostic for intestinal obstruction in a combination of clinical correlation for this patient. Maybe the patient with diarrhea, we have multiple air fluid level also. Normally we have multiple air fluid level appearance. Normally we have three. The one is the gastric gas bubble may form a one air fluid level, and also we can see another one here in the duodenum, but it's not appear in this image. And last one can see in the terminal ileum. This is the normal appearance sites. But if we see a multiple in other sites rather than these three sites, it will be diagnostic for intestinal obstruction, and this is in erect position. But if we go to the supine position, as we see here, there is a dilatation of these loops, and we can see here the valvulely convex appearance of the small intestinal loops. This is linears of the mucosa of the jejunum. This is appearance is due to the jejunal dilatation, and we can see here in ileum dilatation, so the obstruction may be between the jejunum and the ileum. Also, using the barium, we inject through a catheter or rectal catheter through the anal canal, and we inject barium first. Then we can inject gas after evacuation some of this barium to form what's called double contrast barium enema. We can see here this is barium double contrast. We can see cecum, ascending colon, as we see before, hepatic flexure, horizontal pattern of the transverse column, splenic flexure, descending colon, sigmoid, and we can see here the rectum. Also in the X-ray, we can see the appearance of what's called the coffee bean appearance of the sigmoid volvulus. The sigmoid is volvulus on its axis and leading to marked dilatation with distension of the gas, forming the appearance of the coffee bean appearance. Are going to the similar, as we mentioned in the esophagus, we have a multiple diverticular disease or diverticulosis of the colon. It may be appear as an outbouching of this contrast filled or barium filled spaces outside the contour of the colon. And here we can see this multiple diverticuli. Here it's not complicated diverticulum, but if this diverticulum is ruptured, may lead to collection or inflamed, leading to diverticulitis, which is a patient symptoms usually is pain, but it's maybe affecting all parts of the colon, but usually the affected segment is the sigmoid. We can see here also in CT appearance, which this is the diverticular disease in the sigmoid, as we see here, and also in the CT virtual colonoscopy, as we will mention later on. We can do it and see this is multiple diverticular disease affecting different parts of the colon. In contrary, we can see the filling defects, which is not outbouching, but the patient has multiple polyps, which is protruding into the lumen of the colon, so it leads to multiple filling-like defects, as we see here in this part of the colon. We'll see here in the double contrast barium, we can see these rounded areas inside the multiple rounded areas here. We can see it as a multiple filling defects, which is the polyposis of the colon, and we can see here also this is polyps within the CT contrast. We can see here multiple polyps within the oral contrast the patient has. This is occur in the familial adenomatosis polyposis syndromes. As regard colon cancer, it can appear in any part of the colon, including the ascending, descending, transverse, or even the sigmoid and rectum. The typical or classic appearance of the colonic cancer is the apple core appearance. As we see here, we can see here there is a stricture of the colon here. This is the luminal stricture. The barium passing is through the narrow lumen, and we have see here there is a shoulder, another shoulder, another shoulder, another shoulder. These four shoulders forming the appearance of the apple core appearance. But actually, the malignant lesion here or the soft tissue lesion is what I'm drawing here. I will draw it with another color. Okay, as we see here, this is the mass. Actually, this is the annular mass. Okay, this annular mass forming the lumen in between to be structured, and forming here the shoulder, another shoulder, another shoulder, and another shoulder here. Okay. We can see here another example. I can see here the shoulder and shoulder stricture. I can see here a shoulder, a shoulder. It's also a core appearance, but there is no passage of the barium through this structure because it's a marked structure. We can use the virtual CT colonoscopy. The virtual CT colonoscopy is done using the CT machine after preparing the patient with laxatives and multiple enemas to clean all parts of the colon. After that, we inject gas or air through the anal canal to distend all parts of the colon. After that, we image the patient in two positions, supine and prone position. After this, the software, special software, is tracking all parts of the colon, forming this image for us. We can see here there is a stricture here and a mass-like lesion. Okay, here distracting the lumen of the colon, and we can, through the virtual colonoscopy, we can go through the lumen and forming image just like endoscope. We can see here this is the polyps through the arising from the wall of this colon, and we can see here in axial image. We can use the MRI for the imaging of the rectum. It is the most preferred imaging modality for the rectal cancers, because the MRIs can delineate the affecting part of the rectum and its distance from the anal verge. And we can see here there is an abnormal signal intensity of the soft tissue is involving the posterior wall as well as the anterior wall of the rectum. Here is the lateral wall, so there is annular carcinoma affecting the rectum from here to here, and we can see here there is a shoulder and shoulder here. This part is malignant, and we can see also there is a small lymph nodes here. Okay, and that's another one may be affecting here, and this is the appearance of the rectal cancer in the MRI. So the MRI is better for rectal cancer delineation even without the contrast, IV contrast, for evaluation of this rectal cancer. Biliary trees, we can use the X-ray, ultrasound, less likely CT. We can use MRI or ER. Firstly, this is X-ray. We can here see the right lumbar or right hypochondrial radiopaque shadow, which is have a linear linearity, in which if you have hypodense center and hyperdense periphery, it is one of the characters of the cholesterol stone. Also, we can see here a multiple radiopaque shadows in the right iliac fossa. We can differentiate it from being a renal stone in the lateral position. If it's overlying the spine, it will be renal. It's anterior to the spine, it is biliary. But in the multiplicity here, and they are phased to each other and they contacting each other, it's mostly gallbladder stones. Not all gallstones appear hyperdense or radiopaque in X-ray, but all of them are echogenic, which is whitish appearance in ultrasound, forming posterior shadow as we see here. Okay, this is a large stone in the gallbladder, which is this anechoic or black jet gallbladder. We can see here another gallbladder, but we can see here a multiple echogenic whitish stones inside, forming large posterior shadows beneath this or deep to it. We can see here the biliary dilatation within the liver. We can diagnose this biliary dilatation using ultrasound, and we can see also the common bile duct and if there is any stone or content inside. Then we move to the MRCP. MRCP is the magnetic resonance cholangiopancreatography. It is imaging depending on the fluid imaging and attenuating any other tissue. So we can see here the normal appearance of the gallbladder. This is the cystic duct. This is the biliary tree inside the liver. Finally, the common bile duct, the pancreatic ducts, and this is the ampulla of water, and here is the duodenal part. Or common bile any structure or filling defect within this common bile duct lead to dilatation. We can see here a signal void area. It's a stone within the common bile duct exerting some dilatation above and dilated intrahepatic biliary radicals. Here is the pancreatic duct within normal appearance. This is a normal appearance. We can see here a stricture centrally in this image. We can see a stricture or abruption of the dilatation of the common bile duct at the level of the common hepatic ducts. This is central cholangiocarcinoma. But in here we can see the dilated radicals on the liver and the dilated common bile duct down to abruption here, and also the pancreatic duct is dilated and abrupted here. So we can suspect that this area is a malignant mass or a mass forming from the pancreatic head or even the ampullary or periampullary lesion that exerts this stricture on the common bile duct or the pancreatic duct, and this is what's called double duct sign. Also, we can use an ERCP, introducing endoscope through esophagus, stomach, reaching duodenum, and this is through small cannula. We can insert through the ampulla of water and injecting the contrast, and we can through this contrast here see the common bile duct to the biliary tree, and we can see here there is a filling defect within the distal part of the common bile duct. Thank you.